That was a really...
With modern femtosecond laser, we have a lot of possibilities. We can really customize our Capsulorhexis, the size, the location. We can focus on the optical axis or the pupil middle or whatever. And in this study, we used the LensR laser, which has a high-resolution rotating Scheimpflug system. It's not an OCT technology in order to visualize the entire segment, and then a 3D reconstruction with so-called augmented reality in order to show exactly the position of the whole anatomy of the eye. And the lens that you put in is a special lens made that has two big and two small little, how you call it here, some little extra things that will be fixated in the little wings that will be fixated in the capsulotomy. So these big haptics are in the capsular bag, and the Capsulorhexis is around here fixated. And you can see here how we adapt this. One was already adapted. Now the second big haptic is fixated in the capsulotomy, and now we will do here the size, the side, the smaller wings. Like here, we go there, lift it up, so that at the end you have a 360 degrees coverage of the optic inside the Capsulorhexis. There's a certain learning curve to do that. This is one of my first cases. At the beginning, it maybe take 1 or 2 minutes longer for the whole surgery, but then it's quite easy to do. So we had a multi-center trial in 8 clinics in Germany, Great Britain, Spain. 360 eyes were preferred bilaterally implanted, and we had the interims analysis here between 6 and 12 months now. We had a lot of endpoints where we looked at the performance of the lens, and joining forces here with the Department of Applied Mathematics in Heidelberg, who wrote a program to analyze the images. So the images that we had were transferred in an image analysis system, and then rotation, decentration were measured, as well as using pictures from a pentacam for the tilt of an intraocular lens. We could also use that, and this was also automatically analyzed. So when we look at the interim results, 184 has completed 6 months and 84 12 months. So this is not finished yet, but it gives already quite interesting outcomes. So these are the demographics of the surgery, so to say. IOL power was around 20 Capsulorhexis size. With the system was supposed to be 5.0, between 4.9 and 5.1, depending on the laser you used. Incision size 2.4 here, because it's a little bit bigger lens. Surgical time on average was 12 minutes, so it was not such a big thing. The surgeon was supposed to grade the way the femtosecond laser and the implantation was regarded, and you could see that most of this was here in the green area. There is a learning curve, as you can see here. The positioning of the small haptics was a little bit more difficult than the 2 large haptics, of course, but overall the surgeon satisfaction with the procedure was quite good. If we look at the, I guess this is the refraction, and the subtractive refraction, and we could see that there's still some improvement, room for improvement, because they became slightly hyperopic in this. And we have to optimize the A constant, but we didn't have that when we started with the study. So, but nevertheless, 82% were plus minus 0.75, 94% plus minus 1 diopter. So there is a need for A constant optimization, which should be, because the lens is always at the same position if it's fixed in the anterior capsulotomy. So there's not much variability in terms of effective lens position. So on the long run, I think we will have very good outcome in terms of refractive. Uncorrected distance visual acuity here in LOCMA was around 0.8. This is quite good. Corrected, of course, 1.0. So this is quite good. And if we look at the rotation, we have to compare that with what we learned from other studies. And there are several publications where you can see that mean IOL rotation is between 5 to 2 or 3 degrees in for example, in toric lenses. Yeah? Even though toric lenses are specifically made not to rotate, you still have a certain amount of rotation. So how does this compare with this lens? Here you see what's in the literature, 5 to 2.7, and you see here what we've seen here, so it's much better in terms of rotation. What about decentration? Again, looking at the historical group, around 0.3 to 0.4 millimeter decentration has been reported in several studies. And if we look here, there's zero decentration. Yeah, we're here really talking about zero compared to what's known in the literature. So this is quite interesting. Tilt, there are not so many studies on this, but several degrees have been reported, but it's always difficult how to measure it. But some people here for this German group, they did a really big effort to measure it very good. And here we also see that it's much less. We differentiate between horizontal and vertical tilt, and this way the lens is really very stable in the capsulotomy. Here the vertical tilt. This is the comparative group. This is results. PCO is an issue here because the lens is not really pushing against the posterior surface of the capsular bag. If we look what's known about PCO frequency with hydrophilic lenses, it's quite high. In our group now, after 6 months, we had 2 and 3 YAG treatments after 12 months, 3 out of 84 then after 12 months. So it's decent. You can say it's not really a big amount of PCO, but this will be, I think, one of the challenges to make sure that these lenses have no PCO. So here we have a combination. I think it's quite innovative concept to combine femtosecond laser technology, take advantage of it, and apply that to IOL technology. The high precision and repeatability of the femtosecond laser capsulotomy is here the point. We have excellent centration, rotation, no tilt at all. But there's a learning curve for the surgeon to do that, to fixate that in a good way. But it's an excellent platform if you look at this for toric or multifocal optics. However, PCO development is something we should not worry about it, but we should be under observation. But we will see how this performs. This is a 3-year study, so we will see how this will end up. So thank you very much for your attention.
Thank you very much.
Also a main problem of ultrasound. So I would like to take your take, but in Vivinex it is not there.
Yes, that is what.
Yes.
Yeah. Sometimes it actually comes out like this. Yeah, so you have to turn around the whole lens like this, which is even more cumbersome. Yeah. Yes.
Sometimes like this. You have to just rotate it. Sometimes extend it.
Yeah.
So encounter this in Vivinex because I have also practiced some of the Vivinex. I did not encounter that problem in Vivinex, but I encountered that in ultrasound.
Yes, you won't have that with the Vivinex. Yeah.
Do you have experience with ultrasound?
Well, yeah, a lot, quite a bit actually.
So what the difference between the two?
The difference, the basic difference between the Vivinex or the iSert injector and the competing companies is that the Vivinex injector is really a mature product that has been developed over so many years, and the way the lens is set up in it is in a certain framework. It is pushed in. So when you push forward, everything is controlled, and the lens comes out in a loop or in a question mark or whatever. Yeah, but it comes out like this always, and you can direct it directly under the capsulotomy. And you cannot push too hard or too fast because it's a through mechanism.
Yes.
If you have a push-up system and you push very fast, then it comes out more different than if you push very slowly.
So because of this screw system,
yeah, this makes it much safer, and it also is more or less independent from the viscoelastic you use, whereas with the UltraCert, you more or less have to adhere to low viscosity or even to a disperser, so the viscoat or this kind. And with the hook. Yeah, well, Alcon is advocating that, yeah, because these are their own products. Yeah, this has something to do with liability also. So in the iSert injector, it's completely independent from that. Yeah, and as I said, you have a very controlled and always constant force which pushes it forward, because with a screwing system you cannot interfere. You have no chance. Yeah?
You think that it is because of the screwing system that is the main additional advantage?
That is one advantage. It's one advantage. Yes.
For this extended haptic read ultrasound.
Yeah, and the way the lens is already settled inside the injector, and the anterior haptic is guided in a way for when you push it forward that it can only fold like this. Yeah.
So this is the only thing, factor responsible for the difference between the two.
Yes, it's one of the factors. Yeah, there are several factors. The whole concept. Yeah.
No, I fully agree with what Dr. Gerd Auffarth has said. But one thing is certain, with the inserter which we are using with the Hoya, we don't get these problems. And that is one big advantage. Well, because of the screw mechanism, it is always a controlled output. You cannot inject it too fast, you cannot inject it too slow. So it has a benefit.
Yes. Yeah, we made measurements in the lab where we measured the force you need to push it through the cartridge. And with the Alcon injector, you have a very high increase in force. You have to push very hard. And then suddenly it drops down to zero because it kind of releases in the anterior chamber. And with the screwing system, you have a very low force and very constant force, and then it slides out. So it's a huge difference. And you can measure it. You can give it numbers to it. Yeah? And that's why I always say this is a much more sophisticated system. Yeah.
We are now running short, a little short of time. We have to now conclude. We have had a good session, and we look forward to again meeting once again next year and seeing what other new developments we can get with Hoya.